So, good afternoon, everyone, and thank you for joining us today for this rules workshop. I'm Amelia Boyd, and I am the program manager for the Medical Commission. This meeting is being recorded and will be made available sometime next week. The documents which will be discussed here today are available on our website, which is wmc.wa.gov. All attendees are muted. Panelists may unmute themselves and share their webcam. Attendees, if you have a question, please use the raise your hand function and we will get to your questions as quickly as possible. Please note that this is the first workshop for this rulemaking and will likely be the first of many. We have 2 hours scheduled today, and I will begin the roll call of panelists and staff. When I call your name, please introduce yourself. Let me start with Christine. Go ahead and introduce yourself.
Good afternoon. I'm Christine Blake, public member of the commission.
And then Dr. D'Souza.
I don't have my camera's working. Can you hear me?
Oh, okay. Yes,
Okay.
we can hear you.
I don't, for some reason, I can't get the camera to be on, but I'm here. So my name's Anjali D'Souza. I'm one of the commissioners.
Thank you. Heather Carter.
Yeah, Heather Carter, Assistant Attorney General, and I'm the legal advisor to the Commission.
Thank you. And Kyle.
Good afternoon, everybody. My name is Kyle Kiernan. I'm the Executive Director for the Commission.
And Micah.
Good afternoon. I'm Micah Matthews, Deputy Executive and Legislative Director for the Commission.
Dr. Murphy.
Hi, I'm Terry Murphy. I'm Commissioner for District 9.
And then, so thank you, everyone. And then Dr. Domino, please introduce yourself and then you can proceed with the script.
Okay, hi, I'm Karen Domino. I'll be the presiding officer for this rules workshop. I'm the chair of the Washington Medical Commission this year. Today is Monday, September 18th, 2023, and according to my computer, it is now 2:05 p.m. The meeting is being held by a Teams webinar and in person at the Labor and Industries headquarters located at 7273 Linderson Way, Southwest in Tumwater, Washington. The rule being discussed.
Just a minute, sorry, I have the wrong address on there. It's actually, the in-person location is room 145 at DOH, which is at 111 Israel Road, Southeast in Tumwater. Sorry about that.
Oh, thank you for the correction. The rule being discussed today is regarding the general provisions for opioid prescribing and tapering rules in both the Chapter 2246-918 of the WAC for physician assistants and Chapter 246-919 WAC for physicians. Ms. Boyd, please give an overview of the rules process and the proposed timeline.
Okay, so first we'll talk briefly about what is a rule. So it's a regulation that is a written requirement that applies broadly across a group of individuals or entities that enables, guides, or directs them to do something or prohibits them from doing something. And then specifically, it establishes or subjects individuals or entities to penalties if it is violated, or is a qualification or requirement that gives a benefit or privilege, or sets qualifications or standards that an individual or entity must meet to get a license or permit, or sets standards that must be met before a product or material can be sold. And then why are we creating this rule? So part of the reason why we're creating this rule is that the CDC did update their guideline last year. And then we contracted with Dr. Gregory Turman, who was previously a pro tem member of the commission. And then he's also the professor of anesthesiology and pain medicine at the University of Washington in Seattle. We contracted with him to do a comprehensive comparison of the commission's opioid prescribing rules covering physicians and physician assistants to that CDC guideline that was updated last year. And then Dr. Turman was also asked to recommend changes to the WMC's opioid prescribing rules based on the differences found between our opioid prescribing rules and the guideline. And then Dr. Turman provided the WMC with a report, and he titled it Comparing and Contrasting the 2022 CDC opioid prescribing guidelines and the 2019 Washington State prescribing rules. And then based on those recommendations in the report, the commission voted to initiate rulemaking on the following items. Exempting patients with sickle cell disease, and then state in the rule that not all chronic pain patients need to be tapered off of opioids. And then the tip to create clearer rules regarding biological specimen testing. And then the reason we use rulemaking is because rulemaking is the best approach because requirements must be in rule to be enforced. And let me get to my next. So, and then here's our proposed rule development timeline. Obviously, with all rulemaking, this can change. So we filed our 101, which is our pre-proposal last month. We are beginning our workshops this month, and then hopefully by summer next year, we will have draft language that's been approved by the commission, and we will file a 102, which is our formal proposal, and then hopefully we can, by a year from now, have our public hearing, and then the final rule adoption would be October to November of next year, and then in early 2020, that should say 25, not 24, the rules are in effect.
Thank you, Ms. Boyd. To the audience, are there any questions regarding the rules process and the proposed timeline? Ms.
There's
Boyd,
one
can
hand raised.
you call on the individuals? I see Mr. Shepherd.
Go ahead, Jeb. Oh, hold on, let me unmute him again. Hold on. Oh, it says he has no mic. Interesting. Okay, hold on. Let me do a couple things.
Can he text his question or comment?
I'm not sure if he can use the chat. He can attend. He can.
He did reply, said he can ask here. I don't necessarily see everything on it. Maybe Ms. Boyd, do you? It says the timeline laid out here seems to provide opportunity for written, and then I see ... Can't
It
really
says
enlarge this. Yeah.
It says the timeline laid out here seems to provide opportunity for written feedback before the 102 is released, but want to confirm. We need a little time to have physician review. So the timeline obviously can change, but our hope is to have these workshops wrapped up, by June. Well, probably July or May of next year. So 7 months-ish, 8 months. That's our hope. Okay. He said that's plenty of time.
Okay, are there any other questions?
Trying to figure out how to fix him not being able to speak.
Do you see any other questions, Ms. Boyd?
No, I do not.
Okay, The next item on the agenda is discussion and comments. Ms. Boyd, please present the list of WACs which are up for discussion today and the list of items which are to be addressed in this rulemaking.
Okay, so there are lots of WACs. That's only because we're trying to, so I decided to open the patient evaluation for subacute pain and chronic pain sections because I'm not sure, and the periodic review chronic pain sections, because I'm not sure where we're going to put the biologic, the urine test rules. I'm not sure which of those sections it really fits, and we don't really have any draft language for that particular one. So I decided, well, we'll just include these three and hopefully it will fit into one of those. And then obviously we're opening the exclusions sections for both the MDs and PAs, because that's where we'll put the sickle cell disease patients. And then the tapering considerations, we'll try and cover that. Basically, it's just like a statement that not all patients, chronic pain patients, need to be tapered off of opioids. So that was the reason why we are opening these. And then, as I mentioned, these are the items that we're addressing in this rulemaking. We will not be discussing any other sections or any other topics, really. This is a pretty focused rulemaking. It's just to address these three things. And then if we have a question about other items within these WACs that people may want to change, we can ask Heather, who's here to be our legal advisor. It looks like we have another hand raised. Jeb, did you mean to raise your hand again?
I did, and it looks like my mic is working.
Perfect.
Yeah, thank you so much. Just a couple quick questions. Thanks for the opportunity. One is, I know all the professions that prescribe opioids have their own set of opioid prescribing rules. And just curious if there's going to be any effort to sort of coordinate this with the other boards and commissions, especially for osteopathic physicians, so that the rules for our members are aligned as possible. And then I know it's very clear that you are taking these steps to align the state rules with the CDC rules guidelines, and wondering if there will be an opportunity to discuss some other areas outside of the three listed there. For example, there are a lot of documentation requirements in the state prescribing rules that are not present in the CDC guidelines, and I think the interest there would be an opportunity to review all the documentation requirements and just making sure that these are as reasonable as possible within a 10 to 15 minute patient encounter.
So that would be a question for Heather, but I will say we will not be addressing any other sections in this particular rulemaking that are outside of that list of WACs. So if it's not included in that list of WACs and our CR 101 is written in a way that says that we will only be addressing these three items. But Heather, if you'd like to also respond.
Yeah, I think you're right, Amelia, that the way the CR 101 is written, it's really limited to those three items that you've got bullet pointed. If the commission wanted to open the rules further or different sections, they can always do that in a different rulemaking package and do a new CR 101 about documentation. But this one is very limited to these three topics.
Got it. Thank you.
Thank you, Heather. Are there any other questions? Okay.
Ms. Boyd, please share any comments we've received.
So we did receive 2 comments. Let me drop them into the chat. I think it won't let me. So I'm going to get these comments posted to our website later today. For some reason, it will not let me drop them in there, probably because it's a PDF or something. Who knows? In any case, I will pull them up on the screen, and they're very tiny, so I will make them a little bigger. And I think, let me see if Rose is here. Rose, are you here? Oh, she's got her hand raised. Do you want to go ahead and speak?
Sure. Is my mic on?
It is.
Hi there. Yeah, sorry, I did not realize that you guys were limiting it to just the 3 things mentioned, but we sort of took our opportunity while you're cracking open these rules that one, we wanted to add something in here about when you're talking about patient evaluation for patient records. Risk assessment tools are great. We're 100% on board, but this would be a great place to put in some limits about AI and sort of unregulated, systematic, automated decision-making systems that are populating risk scores without validation, without us knowing what's in them. So that would be that change we suggested. The second one we added was just because this has always bothered us in the next section are tapering considerations. It currently says don't taper anyone unless these things happen. And one of them is patient experiences a deterioration in function or pain. But some of us have progressive conditions that are absolutely going to get more severe if, you know, we're lucky enough to live long enough. So adding a clarification that, like, if their pain increases unexpectedly beyond what is expected for their disease progression, that would be a nice clarification to add in there too. And then finally, the third one is 100% add sickle cell. For the love of God, add sickle cell. But also, there's about 100 other critically severe, painful conditions that, you know, I don't think we want to crack open the door to listing the top 100 most painful conditions that maybe should be considered to be excluded. But all of them should be managed under palliative care. Like, I don't think we do this scatter approach of like, this one's severe enough, that one's severe enough. If we had clarification that palliative care treatment is exempted and palliative care doesn't just mean end of life or hospice, we might get clearer understanding of that. And so we asked that if you could call out palliative care on its own line in this WAC to say that it is for the treatment per your own definitions of serious and advanced or life-threatening illnesses, not necessarily end of life. I know it doesn't wave a magic wand and make everyone understand what palliative care really means and get people to use the appropriate coding and treatment stuff, but it's a start and we'd love to see it. That's pretty
Thank
much
you,
it.
Rose.
You're welcome.
Okay, and then we received another comment. Let me see if I can get to it. It's very tiny. So this comment actually came through our website. And so it says, hello, thank you for taking the time to hopefully read my email. I have had chronic back pain for 4 years now. What I have experienced with trying to get answers and treatment through this process is beyond disturbing to me. The medical field discriminates and is downright abusive to chronic back pain. The first thing I would like to address is being forced to have procedures or refusal of treatment of any kind. If you go to a pain management in this state with chronic back pain, you are automatically pushed to do spinal injections. I'm going to paste below what the FDA has on the website and encourage you all to look it up for yourself. So let's see. Where am I? Trying not to like reread all of this. Okay. I'm not sure where, I think I'll start here. We started investigating the safety issue when we became aware medical professionals' concerns about epidural corticosteroid injections and the risk of serious neurologic adverse events. This concern prompted us to review cases in the FDA adverse event reporting system database and in the medical literature. See data some now when I state this to doctors, I am told this is a lie, that these injections are FDA approved. When I say, I don't feel comfortable and I don't want them, I am met with aggression and automatically treated like, well, a drug seeker. Sorry. First of all, lying to a patient is not right. I should be able to trust my providers and know the risk of procedures that are being pushed on me. Now let's get to the second thing that is pushed on back patients in the state, Cymbalta. If you do not know how much this medication, much about this medication, I would again encourage you to do your research. Is being pushed by all your providers. Cymbalta has hundreds of lawsuits filed against it for severe withdrawal symptoms that last months. It literally causes brain zaps. There are literally rehabs to get off this medication and support groups. Again, when I state this to the pain doctor I saw, he got hostile. Told me that chronic pain support groups were for bitter people, said he would never prescribe something that would cause such things. Again, please do your research on this medication. Treatment for chronic back pain. When I started PT, they spasmed and threw my back out so bad I was stuck hunched over, couldn't move without severe pain. I called my primary care, which was booking out over a month. So me not knowing what to do, went to my normal urgent care where I have been taking my kids for years. The provider walked in and her exact words were, "Why are you here? What do you want me to do for you? We don't give meds." I was confused. I went here because I had no idea what was going on, what the physical therapist had done to me, and was scared. She told me to go home and wait for my primary care appointment. Within 3 days, the pain got worse. I couldn't shower myself. My left side was going numb. So I then went to the ER. Again, I got a lovely greeting from a provider that started to lecture me. He told me I was not allowed to go to the ER unless I was peeing myself or could not control my bowels. Said they wouldn't do an MRI otherwise, and they don't give meds. My mother, who is a nurse case manager in DC, had to fly down to help me take care of my children and bathe me while I waited for primary care appointment. As a person, had never felt so helpless in my entire life. I learned really quick that I was no longer treated as a person, but a chronic pain patient. I learned to research everything that was being pushed on me. I am going to counseling for PTSD-like symptoms now anytime my pain hits a level 6. I know I will be left bedridden, screaming in pain when my back goes out. Imagine having pain as bad as labor pains for a month and just having to lay like that, knowing if you take all the strength you have left to try and see a provider, you will get screamed at. I don't want to be on any medication daily. All medications have side effects and withdrawals, nerve meds, antidepressants, steroids, anti-inflammatory, pain meds, muscle relaxers. I should be able to have pain medication for acute flare-ups and severe back pain. I have had chronic pain for 4 years now. I've learned to live with it and accept this is what life has thrown at me. I love my life even with the things I cannot do, but I want to be able to live it. I need to work remotely as I cannot walk or sit for more than 1 to 3 hours at a time. Yet I cannot get pain control or even do in-person training to get a remote position. If I'm in a bad flare-up and my kiddos have a sport tournament or dance recital, I should be able to have pain control to attend the event. Those are the little things that make the struggles worth it. Yet I have to either leave earlier or go to the bathroom and cry instead of enjoy seeing my kids grow. If my back goes completely out, I should not be left unable to move, shower for days, dress myself. It's unhuman and downright wrong. I understand that pain meds, when taken long term, can make you think you're in more pain than you actually are. I understand when taken daily, they cause withdrawal, just like every other med given for chronic pain. You guys set up the rules so we are forced to have monthly injections or have to take daily meds like Lyrica or Cymbalta with dangerous withdrawal. They're even known to cause brain damage. Instead of being able to take 5 to 10 low-dose pain meds a month to manage bad days and give a better quality of life. I have now lived on Aleve and Tylenol daily for 4 years. Do you know what that is doing to my body, my stomach, my liver? How can you really promote what you are doing? You are causing depression. You are causing more health issues by restricting and taking away pain medication. Thank you for listening, and I really hope you create a change. I fight as my son has identical back issues as I do. I hope to change things before he hits 30s and has my issues. I could never imagine my child being left to suffer as I have and pray daily things will change. Kind regards, Savannah. So when we get comments, we have to like respond to them, but this particular comment doesn't really address what we're doing. So we can either, if you would like to respond to that, you can, but we don't have to since it doesn't really address the actual rulemaking that we're doing. Is that correct, Heather?
Yeah, that's correct. So the response isn't directly back to the person. Usually it's just a response in the rulemaking file. So so you're aware of that, it's not like we write a letter back to all of the commenters. This is just a response that you've either addressed or didn't address in the rulemaking. So your response in the file could be you received these comments, but they did not address the 3 items where the rule's currently open. So, I mean, that's one option. If you want to respond more, you can.
Ms. Boyd, are
Dr.
there?
Murphy? Sorry, Dr. Murphy
Yeah.
had her hand raised.
Yeah, did I notice at the top of the long comment, it said unverified?
Correct. So this is one, like I said, this is one that came through on the website. So
Okay.
we have all of our rules posted to the website now, the ones that are in progress, and they can comment on the website now. I'm not sure what, I'm assuming that she didn't leave an email address.
Or a last name or any way to actually comment, respond to
Correct.
it. So we need to consider that as well.
Yeah, I would say no response necessary at this time.
Okay, and then we were going to talk about.
There is someone, if you look in the chat, I submitted my comment through the website as well, and I also, so there may be more website comments.
No, so that's Rose, and she did submit
Mhm.
her comment through the website, and then she emailed it to me as well because it messed with the formatting of her of the comment. So those are the only 2 comments we have. But thank you for that information, Rose.
Okay, so it sounds like, Ms. Boyd, we can move on to presenting the draft language for these items.
Let me get that pulled up. So this is the physician. And so obviously, the one thing that we do have on our list of things we're supposed to take care of is the sickle cell, exempting patients with sickle cell disease. You can consider, let me pull that up over here so I can read it. You can consider or address Rose's, well, it's, the Washington patients and intractable pain. They did suggest adding Hold on. Exclusions. At the end of 3, they suggested adding the provision of palliative care for treatment of serious, advanced, or life-threatening illness. However, we are not addressing the other parts of the exemption section. The only reason we opened this section is to add in the treatment of patients with sickle cell disease. And I think if we want to consider changing the provision of palliative care subsection, then we would have to have a different 101 for that, correct, Heather?
Yeah, you could, the commission could vote to do an amended 101 or a new 101.
Yeah, and I just wanted to make a mention about why we pointed out the sickle cell disease. We were comparing the Washington State rule to the CDC guidelines, the updated version, and they do include sickle cell disease in that, and they specifically call that out as an exclusion. And so that's what, trying to make things consistent, we recommended that change.
Go ahead, Dr. Murphy.
Well, and I applaud singling out sickle cell disease by itself because it's not a chronic pain condition. It is a fatal death sentence to anybody that has the disease and not just the trait. I like number 3, where it's broad enough to include the provision of palliative hospice or other end of life care. And it, we don't need to spell out 100 different diagnoses and then what, miss 3? I don't think we want to be that specific in this. But I like the way it's written now.
I agree, Terry.
Yeah, and I agree as well. It seems flexible. I think, if you have a long list, people aren't going to read it, number 1. And number 2, you may leave out something that you just accidentally miss. And again, the only reason why sickle cell disease was specifically called out is we're trying to make things consistent with the CDC guideline.
So are you fine with the way that this is changed, just adding in the treatment of patients with sickle cell disease? It's pretty similar to what was already established for cancer-related pain patients.
I am.
Okay.
Yeah, and I am too.
I will
I am
move
as
on
well.
to the next one. Thank you. Dr. D'Souza, do you have any comment?
Not yet.
Okay. Let me find. Okay, so the other one is to state and rule that not all chronic pain patients will need their opioid prescriptions tapered. So this is the tapering consideration section. And so I added the sentence and then I changed this sentence to say, relying on medical decision-making and patient-centered treatment, the physician shall consider tapering or referral for a substance use disorder evaluation when. The shall consider, we had a lot of angst about before, because how do you prove that you considered something, it's so, but we've left that shall consider in there. And so I don't know if you like this language or if you wanted to say something different. This is like guidance, and we don't typically put guidance in rule. So
I can tell you, Ms. Boyd, about why we voted for this. We were concerned from feedback from patients that basically their physicians and PAs feel they need to taper the opioid therapy, and they may have been stable on these drugs for 20 years and are doing very well, and it's controlling pain. And what we're saying is you need to think about whether you need to taper them. And that gave this, that's why we put it in, is really to help protect some patients who are feeling that the physicians and PAs wanted to taper the opioids and they had been on them for years.
So I don't know if we want to put something in rule that's really guidance. I mean, I don't know. Oh, Micah, go ahead.
Right, just engaging with legislators and stakeholders, as well as the patient advocates. I will say that there's a great amount of, I guess, need for clarity on this. We've just recently seen a pain clinic closure where the PCPs not involved in the closure itself are being unwilling to not taper in these cases, just as in a bridge prescription scenario. So I think whatever clarity the commission can provide in its rule, even if it is a guidance piece, is probably helpful to include, just because of frankly, the opposition that a great amount of folks have to how the CDC guidelines were developed in 2016, the misapplication that they experienced through both hospitals and other clinics. I think it would benefit for the regulator to be at least clear that tapering is not a requirement in every scenario.
Which is why we took requirements out of the title of this section. That's why it says consideration. So I don't know if you like this language. You'd like to change it. Thank you for that, Micah, by the way. Go ahead, Dr. Murphy.
I don't know how you can make it any more clear where you say not all chronic pain patients will need to have their opiate prescriptions tapered, period. I don't know how you can make that more clear.
Right.
I like the language.
Yeah.
It's very clear.
Yeah.
And then, sorry,
the
change
following,
to the second sentence.
The second sentence, relying on medical decision-making and patient-centered treatment, the physician shall consider tapering or referral when the patient requests. I can't see beyond that.
The rest,
I don't.
yeah.
Okay.
It's a very long list.
I think that clarifies, what Micah was saying about our stakeholders.
I agree. Do we need the first sentence at all, though, then? If we're talking about, so not all chronic pain patients will need their opioid prescriptions tapered. The second says, relying on medical decision-making and patient-centered treatment, the physician shall consider tapering or referral for a substance use disorder evaluation when. Is that clear enough, or do we need the first sentence too? It's really a statement.
Yeah, maybe I would put it in a different paragraph, but I think you need both statements.
And we can certainly move it. Let me see what else is going on here. We could put it, let's see. It could just be a sentence at the end of this section. It wouldn't be numbered.
You want to put it
at the beginning.
Yeah, I
So-
like it at the beginning because it's
Yeah,
important
I
and
was
people
gonna
don't
say.
read everything to the end.
Okay.
Just to be honest, I think that's how people
Yeah.
are.
Can you turn
Yeah.
it into one sentence then? So, understanding that not all chronic pain patients will need their opioid prescriptions tapered, relying on medical decision-making and patient-centered treatment. I don't know. So to make it one sentence so that it's not chopped up. Understanding that not all chronic pain patients will need their opioid prescriptions tapered.
I mean, you could put not all pain patients need their opioids tapered.
And so therefore, something therefore relying on
Rely
medical
on
decision making, just to
medical,
make
yeah.
it just one, clear sentence. That might not be understanding that not all chronic pain patients will need their opioid prescriptions tapered. Something will rely on medical decision making. Something in between
physician?
there. Yeah. Will determine or something. Oh, there you go. This physician shall consider tapering. Or referral for us, so that it's just one sentence that pulls in both.
Would it read better with a comma right there? I feel like it would.
Yeah. Chronic pain patients will need their opioid prescriptions tapered. The physician, relying on medical decision making and patient-centered treatment, shall consider tapering. Or could say the physician shall, just take that out and say shall consider tapering or referral for a substance use disorder evaluation when.
Well,
Instead of
this physician again is
yeah.
redacted, is taken out.
Okay. Oh, got it. Decision
That's
relying
why it's
on
marked through.
medical decision. Sorry.
That's
Oh,
okay.
yeah. And patient-centered treatment shall consider tapering or referral. You're thinking, Terry, I can see.
Yeah, that would work. It's a long sentence, but
I
the
like
first
shorter
is
sentences myself.
the first is just like a flat out statement,
right.
so this kind of puts it together. I mean, it's just a thought, but
Right.
Go ahead, Micah.
Sure. I wonder if combining the sentences is confusing the intent here. So the first thing was not all opioid patients need to be tapered. But the second thing you're tying it into is a referral for substance use disorder evaluation. And I'm not sure those two are connected as far as the intent in the sentence.
I agree as well, Micah. The first sentence is a statement. I think that's important. The second is something different, and I don't think they should be tied together. It ends up being confusing. And it dilutes the importance of the first statements.
I'm fine either way. I have no,
Yeah, I agree. The first statement that not all patients need to be tapered is that is a very essential statement, and one that without this sentence, a lot of doctors misinterpreted.
okay.
Are we good with that now?
Yeah, I'm good with it. It was just a thought.
Yeah, I think the
Okay.
separate sentences are good too.
So then we have our third.
Wait.
Did
Okay,
someone say wait? Sorry.
no. The
So
testing.
clearer rules regarding biological specimen testing. So I have had the worst time with this. I'm not sure how to address it, where to address it. Clearer rules, but what exactly does that mean?
I can just say what I know about the point about it is we didn't want physicians and PAs to dismiss patients just because they had some kind of abnormality on their urine analysis, as an example, because it just cut them off. Because tests don't always work, there may be some reason. Maybe it's a false positive for a certain drug. I mean, there's some kind of issue, and I think that's where it came up. And if I recall, it was in point 10 of Dr. Terman's
Correct.
thing, and that was kind of the point of it. But what to say, I don't know, and I can't see it on my screen, so I'll have to look at it. Yeah.
So that, to address that particular piece, that's why we've opened some of these other WACs, because I'm just not sure where to put it. See if I can. I mean, that's why we've opened patient evaluation, and patient record for subacute pain, because we may need to put identical language in subacute, that whatever we put in chronic, for the patient evaluation and patient record. And then I also went ahead and opened periodic review chronic pain, because there is some 870. Let me find my document. So there's some mention of the biological specimen testing in a couple of those subsections. So don't think
I
it's
believe
there.
the time specified by the CDC was initially and annually, and the Washington Medical Commission was suggesting more frequent urine analysis, which is in contradiction to the updated CDC guidelines, which is annual.
So, I mean, that's a question. Do you want to clarify, like in the periodic review in chronic pain, it says for a high risk patient, do the test quarterly. For a moderate risk patient, at least semi-annually. And for a low risk patient, at least annually. And then also, immediately upon indication of concerning aberrant behavior. And then more frequently at the physician's discretion. So I don't know if we want to change this chronic pain. And to circle back to Jeb's question, if we do that, then we would have to, for sure, I mean, we always inform osteo when we make changes, and then we'd inform the other boards and commissions, because this language is substantially similar, if not the same, as what's in osteo's rules and, you know, the other boards and commissions rules, who also updated their rules years ago. Micah asks, what patient population was being referred to in the dismissal over biological specimen results? I would have to look at that.
I didn't think there was. I thought it was more of a response to patient feedback, that these tests aren't perfect. And with the absence of other aberrant behavior, why not just repeat the urine test as an example, as opposed to dismiss somebody from your care?
Right. That's where
really-
I'm struggling with placement, because we're talking about chronic populations in the chronic patient section of the rules. And I'm wondering if there's a more generalized section that it would fit in. I mean, I know we have our opening intent section that might not be open, but something more along that line is what I was thinking, that could apply to all, you know, acute, subacute, I forget the other one, and then chronic.
So this is Heather, the violation or, tapering or discontinuation of a prescription portion for the UA is in the written agreement for treatment, at least for chronic pain. So it's in 915. So I don't know if that's where you want to.
I did not
address
open that section, so
Okay.
hold on. Let me pull it up. I have to get to the internet here.
Right. So I guess my concern about dropping it in the chronic pain section is it would then not necessarily apply to the other three groups if they were using biological specimen testing and they get an aberrant test.
And if it goes in the intent section,
Right. That's just a wish list. I understand that part.
Mhm.
So
Which, I mean, we can amend this 101 to pull in the intent section instead. I mean, this one's really been difficult to try and figure out
Right.
where to put it and what to say.
would it make sense just to create a new section to address this? Is that I don't know if that's possible. You're the rules.
Sure.
rules
I
committee,
mean,
so
it's not possible within this 101 that we have established because we did not say we would create new sections, but we certainly can do that as a separate rulemaking. That's fine. But again, I still don't know what to say. Like, I don't know what are we going to, are we going to create some requirements? Are we just going to give advice? Because if we're doing advice, couldn't we do that with like an interpretive statement instead? Or just add it in the intent section? I mean, that's not a decision we have to make today, but
I would say that right now it doesn't appear that biological testing is in the acute pain provisions, but it is in subacute, but only if patient's function status is deteriorating or pain is escalating. I think it's most maybe problematic with the chronic pain. I think it's used more there in that situation.
Yeah, I think it's more of a chronic pain section.
Right, I think so too. I don't think anybody routinely tests for anybody with acute pain.
okay, so I have looked up some laws in other states, but they're not very, like, they're not specific to this is what is, an aberrant test, and this, a bad test. This is what isn't. This is when you should be concerned. So they're not real like clear about, they don't give advice about what is and isn't and what they should consider if they're going to like change their written agreement or what have you based on a test. So it's really, and if we do anything, it's going to be, we'll be like the only ones that are really calling out and clarifying this specimen test.
Well, there is still the difference in how often it's done. And maybe there's less, if it's just done once a year as recommended by the CDC guidelines. Initially and once a year, that might make it less of a problem with less frequent tests, right? you're having it done quarterly, there's a high risk of a false positive.
So, I mean, you can change this section if you want. Just keeping in mind that it would be different from, like, say, osteos.
Well, we want to do what the CDC recommends. Right? I mean, that was the whole purpose.
I would be fine with saying that as long as there was a provision that if there was evidence of moderate risk, testing would be indicated to be done more frequently. I mean, if you think about, oh, I only have to do it yearly and the person's kind of, whacking out, but, then the patient may be having a worse problem with substance use disorder by the time you finally figure it out.
Exactly.
So in a way, I think ours is more clinically wise to say, if the patient is calling for, early prescriptions and calling in sick at work more often or asking for their medical leave to be extended, then they would end up in a higher risk group, and that would warrant more frequent testing.
I thought one of the key provisions of the CDC guidelines was in recommending or in providing recommendations along this line was to not dismiss the patient, and I thought that was what we were looking at.
That's
talking
what we're
about is-
looking at mostly. Yeah.
Right.
Yeah.
So here's the recommendation that when prescribing opioids for subacute or chronic pain, clinicians should consider the benefits and risk of toxicology testing to assess for prescribed medications as well as other prescribed and non-prescribed controlled substances. And then the very first bullet point says toxicology testing should not be used in a punitive manner, but should be used in the context of other clinical information to inform and improve patient care. And that clinicians should not dismiss patients from care on the basis of a toxicology test result.
Yeah, I like the CDC statement. And the
Is there a
statement
way
they
we
had
could-
there about testing not used in punitive manner.
Yeah,
Can you
I like that too.
Yeah, can you incorporate that in?
And maybe we could put something similar that Heather, can we say physicians or PAs shall not dismiss patients from care on the basis of a toxicology test result? I mean, that's pretty strong.
That is.
Yeah, I don't know if you'd want to mandate that. I think there's other reason, I'd hate to not allow dismissal of patients if it's necessary. But I think if you wanted to maybe add some of this language into, what is it, the treatment plan? Whatever the open one is.
Oh, the treatment. Okay. Pull it back up. Kyle, you had your hand raised and then it went down, then you raised it again. I'm not sure if you wanted to say anything.
Sorry about that, Amelia. No,
That's okay.
Heather already gave the same advice or the same sentiment that I was going to, so I'm good. Thank you.
Okay. So 855 or the periodic review.
I liked it in the periodic review.
Yeah.
Is where I thought it should be.
Okay. So that's
Because you do talk
870.
about
Right.
violations of the agreement, whatever. EMP tools.
So we could use, I'm going to split screen here. Sorry if that bothers people. If I can get it to work. There we go. There. Okay, so during the periodic review. It's interesting because it doesn't talk about this biological testing for a while. Oh, sorry, Rose, I missed your comment. So Rose says, consider if a formerly compliant patient gets a positive UA for something, require repeat verification tests at some other lab prior to change in treatment or dismissal. Is that something we could require? That they send the patient to another lab?
Can't we just recommend it? I mean, there may be other reasons to dismiss a patient, and the urine analysis is just like 1 of 10, right? I mean,
Sure.
I don't know. We just want to make sure that people don't need to, they shouldn't be dismissing people. And dismissing it should not be used in a punitive manner and should be used in the context of other clinical information to inform patient care. Yeah.
Yeah, I wouldn't want to mandate a separate lab when there can be separate or more specific tests in the same lab. And especially in rural Washington, a different lab could be 100 or more miles away.
And then Rose said that she's not saying for any positive UA, but for a patient who formerly had no unexpected results. So that's something you can consider. Let me look through here real quick. I don't think there's any place in this section that it talks about.
Maybe in section 4 talks about violation of the agreement, and the agreement does talk about biologics. So maybe if in 920 section 4 you put something about the punitive or.
Okay. I'll make it an A. Yeah, this one I need lots of help with this one. So let's see. So what would you want it to say? So again, the CDC says toxicology testing should not be used in a punitive manner, but should be used in the context of other clinical information to inform and improve patient care. So in your rule, if we added it in 4 or under 4, what would you like it to say?
I can't even figure out where you are.
I am right here. I don't know if you
Sorry,
can
I
see it
can't
on your
see it because
screen.
I have the chat on and those questions. I'll try to see it.
So we're in we're just basing all of our changes in the physician section. So we're in WAC 246919920, which is periodic review chronic pain. And Heather was suggesting that we put it in subsection 4.
I mean, you could do just do it as a 5. And I
Sure.
think you can use a lot of, I think we use biologic testing. So I think say that instead of toxicology, but you could, if you wanted to, kind of borrow some of their language.
I was going to ask if we could do that in this paragraph. From this paragraph, I mean.
Okay.
Yeah, I found that section in section 4. Seems okay to me.
Well, you can do it in 4 or you can do it in 5. Sorry, who was that? Was that you, Christine?
That was Karen that said that. I was just saying, asking the same thing. Could we take some of the language and just put it in here?
So we call it specimen or something, don't we? Oh, it just says testing. Okay.
Yeah.
We want to include, but should be used in the context of other clinical information.
Yeah, just
Start
copy
here.
that whole sentence.
Okay.
But not used punitively and in the context of the rest of it. Yeah.
Yeah, I like that whole sentence.
Do we want to add that physicians should not dismiss patients from care?
I was going to ask Heather if you could say something like clinicians should consider not dismissing patients from their care. Do you want, is there something we can put in that, would say that in a way where you're not like mandating it, or just make it a little bit more, before you dismiss your patient, think about it, think about it before you just toss your patient out.
I think that's, what should sort of mean. So if you wanted to say should not dismiss, basis of, toxicology results alone or specimen, or yeah, you could finesse it sort of how you would want, but I think should is not a mandatory word.
That's what I was thinking. Should, if we're not saying must not dismiss.
Should I say, so interestingly in this section,
good.
Yeah, I'm using it. But in this section, it doesn't say specimen, it just says biological testing. So can I just say biological test?
Sure.
Results?
Yes.
Yes.
Yeah.
Okay.
Like that.
Is there one consistent way to refer to it? Because I'm hearing biologic testing, toxicology testing.
So we don't say toxicology testing in the rule. We refer to it as biological, and then sometimes we put specimen in there. I don't know why.
Because the truth is, it's usually urine, but it can be, hair, skin, tissue, blood.
So you have the term biological specimen test or biological specimen testing in your definitions for this section to include urine, hair, or other types of specimens. So I would be consistent and say biological specimen testing. So if people have a question, they can then go to that definition.
Should I change it in the leading, the first pair of the first number 1? Because it just
That's
says
a
biological testing.
testing.
You could, if you wanted, I think it makes it more consistent with the definitions and the terms used.
So in the sentence that you added, Amelia,
Mhm.
The last one, physicians,
Hold on just a second.
Sure.
Get that in there before I forget.
okay. On the basis of a biological test result alone, could we say something like, as this may have adverse consequences for patient safety? May lead to adverse consequences for patient safety.
Is that appropriate, Heather? Is that
Is
okay?
that okay to put in there? Or just leave it like that?
I think
I
you
like
can
it.
if you want to make that.
Yeah, I like to just say, you know, why a little bit. Because this may lead to adverse consequences for patient safety, and we don't have to get into all the, you know, getting more drugs,
Sure.
blah, blah, blah. Yeah,
Okay.
So this is your change then to cover 3, biological specimen testing.
Do you like it, Karen?
I can't see it, sorry. I just can't find it on the computer.
Do you want me to read it?
Sure.
Let's
Is that
read it.
helpful at all? Or actually, can you see the chat, Karen?
yeah.
I do see the
Okay.
chat.
Okay, let me put it in the chat. This is what our new 5 says in 920.
Yes. Sounds
I
good.
like it.
Yeah.
Okay. Thank you.
I hope biologic specimen testing helps the layperson or anybody else reading it. But for a clinician, you have to have a specimen. I mean,
Yeah.
it's
It doesn't.
to me, it doesn't add anything, but if it makes it clear for the patient or anyone else reading it who's a non-clinician, then I think it's good.
Well, and it's the reason is because we defined it as biological specimen testing way
Yeah,
back.
I
Who
get
knows
that.
when.
It's like, what else would you be testing other than a specimen? But that's good. That's fine.
Okay, so Dr. D'Souza, did you have any comments?
Oh, I think that looks good, the language that you've gotten here.
Did you have any
So-
other ideas, Dr. D'Souza?
No. Not right now, no.
So that is the last one we're addressing. So, and thank you so much for that because I've been struggling with it for many weeks. So
Amelia, I just
think-
want to be
Go ahead.
sure that, I mean, the difference in the CDC recommendation for how frequently these need to be done, which is once a year plus more frequently based upon some rationale, as opposed to a rule, which ours is mandating
Right.
it be part of a quarterly, semi-annually, and annually, you know, visit. I still wonder about. I thought part of the reason the CDC went to that recommendation is that the evidence is poor to support it. It's more of a opinion. I know a lot of our rules are opinions. I don't mind that it stay, but I just, you know, we have, because it does vary on the risk to give people an idea. But I would hate to see a doctor or PA sanctioned because they, even though the patient was high risk, they were taking good care of the patient, but didn't do a biological test every quarter. You know what I mean? They could be
Right.
seen every
Sure.
quarter, but I mean, if they're doing well and you have no suspicion, that's,
Also,
So-
my question was, are those risk categories defined? Like, how do you define
They
a high
are.
risk?
Mhm.
Oh, okay.
Yeah, they're defined in the definition section. Kyle, can you speak to that about the sanctions concern?
Yeah, Amelia, the goal of these rules should be to set out guidelines for practitioners. And, in general, this particular consideration with regard to biological sampling isn't something that the commission has used historically as a kind of a sole focal point when considering discipline for a physician, whether it's never really been just the sole tipping point with regard to disciplinary investigation. And so having guidelines that allow the physician's discretion and flexibility to deal with patients as they see fit, I think should be the goal. And I think that the changes that you all have been working on kind of further that. Does that answer your query?
Is that helpful, Dr. Domino?
Well, I see that. The word shall is a strong word.
Yes, it means they must do it.
So, Dr. Domino, are you talking about in 920, the first sentence?
It's under periodic review, chronic pain,
Mhm.
918, yeah. The physician is, I look at the physician assistant one, but it said shall periodically review the course of treatment for chronic pain. Then it says, which is, I think shall is fine there. Then it says the frequency of visits, biological testing, and PMP queries must be in accordance based upon the risk category. That's where I get worried about the word shall.
So Dr. Domino, are you suggesting that instead of must in that sentence, we should change it to should?
Isn't should more less binding?
I think it does allow
Must and
physicians.
shall are
Mhm.
seem very strong terms.
I
if
like
you
that,
wanna
Kyle,
follow with-
changing must to should.
I think that, again, if the goal here is to allow physicians the discretion to deal with patients, that's the change that you want to make, is changing the must to should.
Must, or I mean, should or may, or but not a must.
And
So Heather,
another,
your thoughts?
yeah, this is another option. If you wanted to kind of decouple the biological testing from this and have that be a separate section, but if you still wanted to require a visit quarterly and a PMP check, you could take out biological testing here and add it at the end and talk about that annually for everyone, if that's concerned. But I think you could do it either way. You could change it to should, make it less binding, but that then in turn will also make the frequency of visits and PMP checks less binding.
So,
Yeah.
I mean, my suggestion would be what Heather said, was uncouple the biological specimen testing. Because don't you want them checking the PMP
Yes,
quarterly?
we do. I think we do, if they're high
Okay.
risk. And it'd be good to see them if they're high risk.
Gotcha.
Whereas the CDC particularly made this change, as they were saying in recommendation 10. And there was before starting opioids and periodically, at least annually. Consider the benefits and risks of toxicology testing. I mean, they don't even say you have to do it.
Mhm.
Okay. Yeah.
So what we could do is remove biological testing from this first paragraph. Frequency of visits, take this out, and PMP queries, blah, blah, blah. And then I think in doing that, do we have them do it anywhere else? Let me check.
I think it needs to be, I don't see it in the list,
So in
the rest of the
subacute,
list. Yeah.
yeah, so in subacute pain, so this, I'm looking at 246-919, 895, which is patient evaluation and patient record, subacute pain. So it says prior to issuing an opioid prescription for subacute pain, the physician shall assess the rationale for continuing opioid therapy as follows. And then let me put it over here too. And then it says in E, obtain a biological specimen test if the patient's functional status is deteriorating or if the pain is escalating. And then it does talk about an action plan for any aberrant biological specimen testing results and the risk benefit analysis if opioids are to be continued. I think we could probably add, because we have this section open, we could probably add in here the same language that's in that periodic review. Add it after this one as an I, little baby I. Let's see. Let me go find my. This is why I need 800 screens to do rulemaking. This- Rose has a comment. She says, see my earlier point about pain escalating. Subacute and chronic patients often have progressive conditions. Does the current language reflect that pain can escalate unrelated to the prescription dosage? Should specimen testing frequency be tied to pain severity? So I'm going to let you professionals answer that question. It's in the chat if you need it.
I mean, I think people know that pain can get worse, right? So to me, it's unrelated to the dose. And specimen testing, should it be tied to pain severity? I don't think so, myself. I mean, it should be considered. That's, and the CDC gives recommendations for when to consider it.
Yeah, I agree with Dr. Domino.
So do we. Okay, then Rose says that section just said
Isn't
decrease
that
in function or increase in pain.
that's subacute though? I think chronic may be a little different to me.
Yeah, I'll go pull it here in a second. Do you want to add this language in this subacute section? Sorry, I will get back to the name of it. Patient evaluation and patient record subacute pain. And then it talks about prior to issuing an opioid prescription. And then says the physician shall assess the rationale for continuing opioid therapy as follows. And then it goes through all of these items. And then in 2 talks about that. Hold on, let me get to where we're at. Yep. Okay, so 2 says the physician treating a patient for subacute pain with opioids shall ensure that at a minimum, the following is documented in the patient record. And then E for that one, it says the action plan for any aberrant biological specimen testing results and the risk benefit analysis if opioids are to be continued. And so if we just add this in here for subacute, which is the same language that we had earlier, is it appropriate there? Do you want it there?
I didn't think it needed to be there, but happy to hear what others think.
Well, it makes the document longer. And if we're repeating paragraphs that we have in other places, I'm not for that.
Okay. And the other place was. No, that one. Okay, so is there any other section that we have opened that we would need any more information about the biological specimen testing? I think the answer is no, because you don't want to repeat that paragraph in any place but chronic pain.
Right.
Heather, do you think we need to include it anywhere else? I'm trying to look through my.
I think it's just up to the commissioners how they want to do it. I don't think you have to.
Okay, thank you. Okay, so if that is the case, then we're done with draft language in the very first workshop. So we might not have many more. I think we should have at least one more, or I can bring this draft language to the October 20th business meeting, and you can vote on it at that time to move it forward to the next step in the process if you feel like that no more work needs to be done. Now, what I can do is I can send this out I'll post it to our website, the draft language. I'll post it to the website, and then I will send that link out to all commissioners and to the public, and I can gather comments in the meantime.
That sounds good.
Okay, I will do that then. And then, so we can, I guess, if no one else has any comments about the draft language, we can move along to the next part in the script.
Are there any additional questions or comments about the draft language? I think there were some separate things that were brought up, but Ms. Boyd, do we want to take any more of those comments to consider for further rulemaking on those? Or how do you want to deal with that?
Well, I mean, certainly we can take other comments on these sections that are open, as long as they're addressing those 3 items. If anyone has any comments about those 3 items, let me pull it back up. And there's no hands raised.
Yeah. All right. Are there any questions from attendees that have not been answered?
So I did want to address Jeb's question. We didn't really answer it. So as far as the other boards and commissions who have similar rules to us, what typically happens is if we make a change to a substantially similar rule, like I mentioned earlier, we will inform osteo and dental and all of those folks. They tend to keep an eye on what we're doing anyway. When it comes to opioid prescribing. So, but I will certainly reach out to their program managers and let them know that this is a possible change we're making. I'll send them the draft language, and then we'll get comments back from them. And then what usually happens is they bring our draft forward to their next business meeting, and they discuss it and decide if they want to do something similar or open rulemaking in the same way. So, I mean, that's really up to them if they want to do that. Sometimes they don't. But typically osteo does I mean, we tend to mirror what they do a lot, and they tend to mirror what we do. So I think they're actually working on the patient exemptions that we just finished, adding in all of those facilities. I think they're finishing that up right now. So did you have something to add, Heather?
I was just going to say they did adopt this exact same provisions for the nursing homes and those exclusions. Their next board meeting is December 1st. So that's the next time they would need to consider what you have.
So did that answer your question, Jeb, if you're still here?
It does, thank you.
Okay. Right, that's all I have on that.
I thought there was maybe another question that came through, but I don't see it right now, so maybe it was an old question. There, hand raise. Gina
Okay.
Robert Shaw.
Oh, Gina, if you want to go ahead. Says she's self-muted.
Okay, I took a lot of notes and I have a lot of questions and statements, but the one I'd like to make right now is regarding with the biological testing. I haven't heard anyone mention GSR tests that, from what I've read and understand, a lot of reputable labs will do if they come up with a positive. And it often will rule out. I can tell you on my part, several years back, I was supposedly, they found morphine in my system, which I did not take. And what I have learned, and my doctor, of course, wouldn't even talk to me. But what I had found out afterwards was that had they done GSR testing, I'm sure they would have found it was ibuprofen, because I remember taking extra that morning because I was in a lot of pain. And I don't know if some of you could research this and perhaps suggest this as a possibility, although I know it would cost more money. So I don't know how doctors would feel about that. But I just wanted to check on that and ask.
I can just interject as a clinician and a physician that the rules would not instruct a doctor exactly what test to order, but we are aware of such testing and you know, hope that it would be used as it's appropriate.
Thank you.
Are there any other questions from attendees that haven't been answered? There was a question about what GSR means. What's that stand for?
Yeah, I'm not sure, but I looked it up and I found galvanic skin response. That's the only thing I can find that might be.
Yeah, and I don't know. That was your Google search for it.
Yep. Other than it did come up with gunshot residue mostly. So
Yeah.
I don't think that's it, but
That's the more common thing. Yeah. Yeah. All right. Any other questions? If not, then thank you for your participation. Ms. Boyd will now discuss next steps and provide contact information.
So our next steps is, it says another workshop will be scheduled soon, but like I discussed, I think the next steps will be to post this draft language to our website, gather comments, send it out to the other boards and commissions, let them know that we'll be presenting it to the full commission at our next business meeting, which is October 20th. And at that time, they'll decide if they want to make changes. If they do, then we will hold another workshop. If they decide they like the draft language, then we will move along to the next step in the rulemaking process. And so that CR 102 will come up far faster than what we have in our proposed timeline. And then if there's any questions or further written comments, you can send them to medical.rules@wmc.wa.gov, and those come to me. So I will make sure that the commissioners see them if we get them. And then if you have any questions, you can send them to that address as well.
Thank you, Ms. Boyd. Is there anyone else who wish to comment before we close the meeting?
I just want to give kudos to Dr. Greg Turman for comparing these two documents and putting them in tabular form. I think that was a Herculean task and he did it very well.
Yeah, I agree as well. And I did mention that to him as well. It made it very much easier for us to figure out where the differences lied and what were important, and we needed to make adjustments. Anyone else who wish to comment? Well, if there's no one else who wishes to speak, I will now close the workshop. Thank you so much for attending. We appreciate all of your comments and input. Thank you.
Thank you.
Thank you, everyone.
Thank you.